much for inviting me to give this talk on vestibular evoked myogenic potentials. Unfortunately, even though I had planned to be there in person, the COVID measures that are still taking place have prevented me from coming to Dubai from Cyprus. So at least I can give this virtual talk here. Of course, I've given this talk on many occasions. Maybe some of you have seen this talk before. I will give the background to VEMPs in the initial part of this talk, but perhaps in the latter half of this talk, where I will be presenting actual clinical cases that I've seen, that this will be the first time that you'll be seeing these cases. This is my conflict of interest slide with various honoraria that I have received in the past. So there is no need for this audience to go into the details with regards to what the vestibular system is, of course. What I would like to emphasize on this slide is that vestibular evoked myogenic potentials is responsible predominantly for recording function from the otolith organs of the inner ear, namely the saccule and utricle, which are responsible for sensing linear acceleration and their pathways both through the peripheral and the central nervous system, including the brainstem and the upper cervical spinal cord. Now, if you are familiar with evoked potentials in general, you are aware of the fact that the stimulus that needs to be given has to be of short duration, short rise time, and to be reproducible and easy to have done to the patient. And initial attempts involved using rotating chairs, placing patients in chairs that rotated and stopped suddenly, or allowing the head to drop from a horizontal position. Of course, and these stimuli were used because initial attempts used natural stimulation. In other words, that which the vestibular system is designed to detect. In other words, head acceleration. But as you can understand from this description of the stimuli used initially, that placing a patient in a rotating chair or allowing the head to drop was a difficult stimulus for the patient to undergo. It was difficult for the patient to do, unpleasant. And these stimuli were also difficult to reproduce. But since around the 1990s, it was discovered, mainly by the group of James Colbatch in Australia and also other investigators later on, that sound stimulation, a stimulation that we normally use for brainstem auditory evoked potentials, for example, can also be used in vestibular evoked myogenic potential testing. And as you know, sound stimulation is something that is reproducible, is something that all evoked potential systems have, and is something that is simple to do with regards to stimulation, of course. Unlike standard evoked potentials that we are familiar with, vestibular evoked myogenic potentials are recorded from tonically active muscles. But again, this examination is non-invasive. In other words, there are no needle electrodes involved. There are no needle recordings involved. Everything is done from the skin surface, and therefore this examination remains a non-invasive method. A non-invasive method of recording function and dysfunction from the vestibular system. The best stimulus to use with regards to sound stimulation, and if your system has this, is to use specific frequency stimulation or tone stimulation, more specifically 500 Hertz. If you only have clicks on your system, and I am aware that there are many evoked potential systems that only allow you to do click stimulation and not frequency stimulation, you can use clicks. And I will explain this later on in more detail. But if you are able to do tone stimulation, 500 hertz is the best sound stimulation to stimulate the vestibular system, and you need a sound intensity of 90 decibels above average hearing threshold. We are, of course, talking about air-conducted sound stimulation, and this is the emphasis of my talk. My talk will emphasize air-conducted sound, either using earplugs or standard headphones. Bone-conducted vibration, either on the mastoid or on the forehead, can be used as well, but I will not discuss this in this talk. And also electrical stimulation can be applied over the mastoids to stimulate the vestibular system, but less and less laboratories are using galvanic stimulation, as this is something technically difficult to do. Now, how is it possible for sound stimulation to stimulate a system responsible for detecting head acceleration? So this is a diagram of the ear with the outer, middle, and inner ear, with the vestibular end organs located immediately behind the oval window and the cochlea located to one side. Now, normally, sound of normal stimulus as one would use or one would hear during natural or normal speech, sound at this intensity, when moving from bone conduction to liquid conduction, these sound waves normally move laterally as they move from solid to liquid. So there is a diffraction, if you like, of sound waves, and they move in a lateral direction. And that is why the cochlea is located to one side. But when you use sound of the right stimulus intensity, the right power, these sound waves, before moving laterally, will move forward, and they will move the membranes of the sacral and the utricle, set up sound waves in the endolymph of the otolith end organs, move the hair cells responsible for the vestibular system, and send an evoked potential down the vestibular nerves, both the superior and the inferior vestibular nerve. And as I show in this diagram, and which is important in the ENT field, we can separately record function from the superior and the inferior vestibular nerve, which is important, for example, in cases not only of superior, but also of inferior vestibular neuritis. And as I mentioned earlier, we can use this examination to detect dysfunction in the central vestibular pathways, not only in the brainstem, but also in the upper cervical spinal cord, which will interest your colleagues in the neurology field. And in fact, if you do start doing this examination in your laboratory, your neurology colleagues down the corridor will be interested in sending their cases to you to rule out specific brainstem dysfunction and also upper cervical spinal cord dysfunction as well. So like I said, for VEMP, the best stimulus is 500 hertz tone stimulation at an intensity equivalent to 90 decibels above average hearing threshold. If you only have clicks, you can use clicks, but you need to go to at least 100 to 110 decibels above average hearing threshold to achieve the same power that you need to get across the perilymph barrier and stimulate the vestibular end organs. 50 stimulations are enough to average to obtain a vestibular evoked myogenic potential. So there are two main types of vestibular evoked myogenic potentials. The first that I will describe is the one that was discovered first, the cervical vestibular evoked myogenic potential. Again, surface recordings are used, and record, in this case, over the tonically active sternocleidomastoid muscle and on the same side as the ear being stimulated. So if you are stimulating the left ear, you record over the left sternocleidomastoid muscle. And this examination records mainly sacral function. I say mainly because there is some utricular stimulation involved with regards to the cervical VEMP, but it's mainly sacral function that you are recording, the inferior vestibular nerve, and also specific structures in the central nervous system, including the vestibular nuclear complex, medial vestibular spinal tract, and upper cervical spinal cord. And the response is mainly an inhibitory one. The setup is simple. 3 electrodes are used. The active electrode is placed over the middle of the sternocleidomastoid muscle. It's easy to find this muscle. That's why we use this muscle to record the cervical VEMP. You can use other neck muscles as well. There are reports in the literature of the use of other cervical muscles as well, but the sternocleidomastoid muscle is the one most used and easiest to find. So for example, if a patient is in a lying down position, if you ask the patient to lift the head up slightly from the pillow, you will be able to see this. If a person has a fat neck, you can feel the contraction if you can't see the muscle. So the active electrode is placed over the middle of the sternocleidomastoid muscle. The reference electrode is placed over the middle of the clavicle, and the ground electrode is placed either on the forehead or on the sternum. It doesn't matter where, as long as the ground electrode is near the head. We routinely place the ground electrode on the forehead. So, like I said earlier, at the same time, you need to contract the sternocleidomastoid muscle to be able to see the VEMP response. So if you have a bed available in your laboratory, you ask the patient to lie down. Better to have the patient to have the pillow slightly above the horizontal. This will make it easier for the patient to lift the head up from the horizontal position. So you ask the patient to lift the head up slightly from the pillow. You don't need to lift the head up too much. The instructions that we give to the patient is that they lift the head up from the pillow such that they just don't feel the pillow below the head. Just a little bit, about an inch, and will be enough. And this will allow the patient to cooperate, especially in the elderly, so that there is less exhaustion and you will get good responses there as well. If you do not have room in your laboratory for a bed and you have the patient sitting in a chair, you ask the patient to turn the head away from the side of stimulation. So if you are stimulating the left ear, you ask the patient to look towards the right. Essentially, not preferably, but essentially, you do need to ask the patient to put some resistance because you need to have maximum contraction. Asking the patient just to simply look away, yes, there will be some contraction, but perhaps not enough. So asking the patient to put resistance on the turning of the head will allow you to get higher amplitude responses. So this is an example of a cervical vestibular evoked myogenic potential. You see the contraction of the sternocleidomastoid muscle in the background, and when the vestibular signal reaches the sternocleidomastoid muscle through the brainstem and from the inner ear, there is a very transient inhibition of muscle contraction, and this is what you see. So this is an inhibitory response. And you measure the first positivity, which occurs at around 13 milliseconds. And then you measure the following, the initial positivity, and then the following negativity. And then you measure the amplitude from P13 to N23. So this is the latency you usually measure. And then the amplitude is from P13 to N23. What I show you below is the EMG, or the muscle contraction of the sternocleidomastoid muscle without sound stimulation. The reason I show you this is that it is important to monitor the contraction of the muscle. Now, when I say EMG, again, I do not mean needle EMG recording. This is again a surface recording, and I am using the same electrodes that you are using to record the cervical VEMP response. This is simply another program that I'm using on my system that allows me to rectify the signal and allows me to record the EMG, or the muscle contraction, without sound stimulation. The reason we need to monitor, or better to measure the EMG, is that the larger the contraction, the stronger the contraction, the larger the CVEMP response. And you need to monitor the contraction to be able to restrict the variability in your measurements. Because if you do not monitor EMG in some way, your amplitude values will be too variable to be used clinically. Your standard deviation will be very large, and it will be very difficult for you to set the upper and lower limits of normal of amplitude. But if you're able to measure or to record the EMG by dividing the amplitude of the EMG into the amplitude of the CVEMP, you will get a ratio. And this ratio will be better to use, and you will be able to control the standard deviation or the variability of your response. The stronger the contraction, the larger the CVEMP amplitude, but the ratio of the CVEMP amplitude to the EMG amplitude will be constant for that specific person, for that specific patient. So the variability will be less, the standard deviation will be controlled, and you'll be able to set your plus and minus 2.5 standard deviations from the mean and have a definite upper and lower limit of normal with regards to amplitude. In this specific case, corrected amplitude, corrected or normalized with respect to the EMG. And what do we mean by EMG rectification? As you may know, the EMG is composed of positive and negative phases normally, as shown here. So if you average this response as it is without doing anything, your mean value will be 0. And as you know from mathematics, you can't use a 0 value and divide it into something because the result will be infinity. So you need to rectify the response, and rectification simply means to make the response either all negative or all positive. That way, when you average this signal, you will get a specific value that is not 0, but has a specific value. And when you divide this value into the CVEMP amplitude, you will get a specific ratio that you will be able to use as a parameter, which will not depend on the level of contraction. You may not have this ability on your system, but you may not know where it is. As with all things in this talk, I will give you my email at the end of this presentation. Any questions with regards to methodology, or how can I do VEMPs on my specific system, you can send me a message on my email and via Skype or any other video call. I can help you with your specific system and help you on your specific system how you can do VEMPs. And I'll mention this again towards the end of the talk. And this is an example I show here of why it is important to monitor sternocleidomastoid contraction. So this is an example of a patient with left ear stimulation and right ear stimulation, left sternocleidomastoid recording, right sternocleidomastoid muscle recording. And you may see here an apparent asymmetry in the response, but there is no asymmetry. This is a normal response. The reason the response is larger with left ear stimulation was because the contraction of the muscle was larger with left ear stimulation. In other words, the contraction of the left sternocleidomastoid muscle with regards to this specific person was larger when I was stimulating the left ear. When obtaining the ratio, the EMG ratio, the CVEMP ratio to the EMG amplitude, the ratio was similar on both sides, 5.23 here and 5 on the right. So there is no asymmetry when you take the sternocleidomastoid muscle contraction into account. So it's important to monitor sternocleidomastoid muscle contraction, something that many publications in the literature fail to reveal. Now, if you have a brainstem auditory evoked potential system in your laboratory, you can do VEMPs as well. This is a list of the parameters that you can change on your biopsy system, for example, that will allow you to do VEMPs. If you can change the gain, that will be good because that will give you larger amplitude responses. If you can't change the gain and you can only change the frequency, bandwidth, and the sensitivity and the sweep, that is okay. You don't have to take this down. I'll show you parameters for the OVEMPs as well. If you do not have access to this PowerPoint presentation after this lecture, like I said, I will give you my email at the end of this talk, and I can send you my presentation to your email, no problem. As with anything, and I was given my email at the end of this talk, including parameters, including this presentation, I can send you my presentation to you, no problem. And we have published international guidelines on how all laboratories can do cervical vestibular evoked myogenic potentials in the same manner. And we published this in 2014, and you can obtain this publication. The second example of VEMPs is the ocular vestibular evoked myogenic potential, which was discovered later around the year 2000, 2005, if memory serves. This is different from the cervical VEMP, where instead of recording from the sternocleidomastoid muscle, we record over the inferior oblique muscle of each eye. Again, there are no needle electrodes, there are no needle recordings. Everything again is surface recording. The difference here also is that we are recording below the eye, opposite to the ear being stimulated. So as I will show soon, the recording electrodes are placed below the eye, surface recording over the area of the inferior oblique muscle. If you are stimulating the left ear, you record below the right eye. So this is a crossed pathway, and vice versa for the right ear. And in contrast to the cervical vestibular evoked myogenic potential, we record this time mainly utricular function. Again, I say mainly because there is a saccular component to the ocular VEMP, but it's mainly utricular, superior vestibular nerve instead of the inferior vestibular nerve. And then we go into the brainstem and rostrally upwards instead of caudally, in contrast to the cervical VEMP, moving towards the midbrain. And this time the response is mainly an excitatory one. The setup again is simple, again with 3 electrodes. Again, the ground can be placed either on the forehead or on the sternum. It doesn't matter where, as long as it's near the head. The recording electrode is placed below the eye, in the middle, as if you have the patient looking in neutral gaze, you place the recording electrode below the level of the cornea, and you find the orbital ridge. So you find the orbital ridge in which the eyeball is sitting, and you place the recording electrode in the middle over the orbital ridge. You place the reference electrode below the active electrode. There are references in the literature about having a distance of 2, 1.5 centimeters, 2.5. It doesn't matter. You don't need to take a ruler, or as long as the reference electrode is not touching the active electrode, and below that, that is okay, and that is enough. Again, we need to have an active inferior oblique muscle, but in this case, the movement is to ask the patient to look up as much as they can, as much as they can. The more they look up, the larger the OVEMP amplitude. And the best way to ask the patient to do that is to have a mark or a point for a person to look at. And they need to look at this mark with difficulty, because when you asking the patient, for the patient to say to you that they are looking at it with difficulty, it means that indeed they are looking up as much as they can to see the point. If you have the person in a lying down position, you have the mark behind them on the wall behind them. If the person is sitting in a chair, the mark is on the ceiling. But again, you need to place the person in a position that they must look at the mark with difficulty. That way, the upward eye deviation is as much as possible. Avoid sideward eye deviations, and this is why you need to have the mark, so that you can have the patient looking up vertically and constantly. And this is an example of an OVEMP response. Instead of an initial positivity, you will have an initial negativity. So you measure the latency of this initial negativity, and amplitude is measured from this initial negativity to the following positivity. So you measure the amplitude here. You do not need to monitor EMG in this case. As long as the patient is looking up as much as they can, you will get the maximum response. And this will also reduce variability between your patients, your normal controls and your patients. And indeed, if you are starting to do this examination in your laboratory, please, please, please obtain your own normal values. Do not rely on the company system to tell you what the normal values are, because your normal population will be different, your methods will be different, your recording positions and electrodes will be different, and your room will be different, and whether your patient is in a lying down position or sitting in a chair. So please obtain your own normal values, and your upper and lower limits of normal in your laboratory will then be more reliable. If you have questions about this, again, you can send me an email and I'll be happy to help you with that. Again, parameters that you can change on your system if you already have a brainstem auditory potential system. I can send you these parameters, send me an email, and I can send these parameters to you, no problem. For this audience, I will show you this diagram that this is recorded. This is a waveform that I have that is recording from the sternocleidomastoid muscle. It looks like a CVEMP. It has the same latency as the CVEMP, but this is not a VEMP. This waveform is recorded without sound stimulation. The patient does not have headphones over his ears during this recording. The reason that I'm showing you this is that you are recording with regards to both CVEMP and OVEMP, you are recording from a tonically active muscle. So during the recording, you are also recording motor units, and motor units that are firing at a frequency of 10 Hertz. All muscles fire motor units at 10 Hertz with almost no exception. And as you are stimulating at 5 Hertz, because this is what we normally ask you to do, that when stimulating the vestibular system with sound stimulation, we require a 5 Hertz stimulation rate. So it's very easy to, in the absence of a VEMP, to lock onto a motor unit. So if you don't record 2 trials at least, or if you try too hard to obtain a VEMP, in other words, you do many attempts to record a VEMP, you will very likely lock onto a motor unit. So you may average a motor unit instead of a VEMP. So why am I saying this? It is important to record at least 2 trials. You need to record at least 2 trials, because if it is a motor unit that you are recording from, it is very likely that it will not be reproducible if you do 2 trials or even 3. So you need to do 2 trials. There are many publications in the literature that only show you a single trial, which is wrong. You need to record at least 2 trials to make sure that you are recording a VEMP and not a motor unit. And also, if you try too hard, in other words, if you do a recording and you don't get a response, and you think maybe the patient isn't contracting well, and you do a second time and the third time and the fourth time, it is very likely that by the 4th time or your 4th attempt to record a VEMP, you will lock onto the same motor unit. And again, it will be a motor unit, again reproducible, but it will be a motor unit. So it's very important from the very beginning to make sure that your patient is contracting correctly. That way you don't have to worry about doing 2 or 3 or 4 trials. So try to get the contraction well the first time. And also, yes, maybe your patient will not contract well the first time and you do a second attempt, but that's as far as you should go, because there is the danger that you will average the same motor unit that will look like a VEMP, but it won't be a VEMP. So to summarize with regards to vestibular evoked myogenic potentials, sound stimulation, either tones or clicks, preferably tones, because this will allow you to use a lower sound intensity. And there is an advantage to using tone stimulation with regards to Meniere's disease, and I will describe this later on. Clicks, yes, you can use clicks if you only have clicks, but you need to go to at least 100 to 110 decibels above average hearing threshold. Tone stimulation, 90 decibels is enough. 50 stimulations is enough. I'm sorry, this is an old slide. I used to do 100 to 150 stimulations, but with time and with getting better at the technique, 50 stimulations is enough to average. And the recording is performed from the tonically active muscle, from the ipsilateral sternocleidomastoid muscle with regards to CVEMPs, which records mainly sacral function and its pathway, and the contralateral inferior oblique muscle with regards to OVEMPs, which is mainly utricular function and its pathway through the central nervous system. So that's with regards to the methodology of vestibular evoked myogenic potentials. I will now go into the clinical applications, and my way of presenting this, my preferred method, is to show you actual examples of cases that we've seen in our laboratory, rather than giving you a list of conditions that you can or cannot apply with regards to vestibular evoked myogenic potentials. And we published this as a review back in 2019, a critical review where you can read this, and there was a literature review of what existed at the time. But I will show you other examples here as well. And a slide that I always like to show is the ability that you can record VEMPs in the elderly, despite references in the early literature stating that you cannot, especially above 60 years of age. With the right contraction and the right methodology, you can record VEMPs in the elderly. In our experience, you can. This has never been a problem. For example, and this is an example of a patient, 86 years old, a CVEMP with an amplitude of 86 microvolts. So where you expect to record VEMPs in the elderly from the history, you can record VEMPs. So you can record VEMPs in the elderly despite what the earlier literature says. How you contract the muscles is important. I won't go into the details with regards to this audience, with regards to neurological applications, but you can, and there are cases where you can record central nervous system dysfunction using vestibular evoked myogenic potentials, especially with regards to the brainstem and the upper cervical spinal cord. What I would like to show you here is the common problem that you may find in your laboratory or in your clinic with regards to whether a patient has Meniere's disease, hydrops, endolymphatic hydrops. As I put this in quotation because, as you know, endolymphatic hydrops is a histopathological term, and whether a person has an increase in endolymphatic pressure in the inner ear and has symptoms, there's not usually a one-to-one correlation between whether a person has hydrops and whether a person has Meniere's disease. But for the sake of this talk, Meniere's disease, I will use the term endolymphatic hydrops or a hydropic condition for the sake of this talk. But as you may know, there is no one-to-one specific correlation as such. I don't need to go into the details with regards to yourself as an audience as to what Meniere's disease what vestibular migraine is, what I can state here is that it can be difficult sometimes to differentiate between the two. Yes, Meniere's disease can be associated with tinnitus, but also vestibular migraine can as well in some cases. Migraine, vestibular migraine, yes, but there are not only Meniere's disease, but other peripheral vestibular conditions that can present with migraine episodes. And also, if that is not difficult enough or complicated enough, there are some cases of patients that can have both Meniere's disease and vestibular migraine. And something I like to show here, an experience that we have in these cases, and in those that are presented to us with regards to referrals, that if you have a patient with spontaneous vertigo episodes, if there is a normal audiogram, this does not equate with vestibular migraine, especially when you have that gut feeling or from the clinical presentation that you feel that the patient does have a hydropic condition, and yet you are presented with a normal audiogram. A normal audiogram does not mean that your patient, after all, has vestibular migraine, because you can have an endolymphatic hydrops or a hydropic condition that does not involve the cochlea, at least not yet, hence the normal audiogram, and you may have a hydropic condition, at least initially, or may remain there, remaining in the vestibular labyrinth, which will result, for example, in an abnormal VEMP or abnormal caloric response, and you will still have a normal audiogram, but this may still be Meniere's disease. Now, how can we use VEMPs to help differentiate or to rule in or to rule out whether a patient has either Meniere's disease or vestibular migraine? And this is the advantage of having tone stimulation on your system, because VEMPs normally in the majority of the normal population, I say the majority because there are some exceptions, hence the importance of obtaining your own normal values, that the majority of the normal population have a better response at 500 Hertz, although there are some exceptions, important exceptions. When there is endolymphatic hydrops or a hydropic condition, you will get a better response. Instead of at 500 Hertz, you will get it at 1 kilohertz. And this is what the literature refers to as frequency tuning, where the maximum response, your maximum or better VEMP response, I say better rather than maximum, because the better response can manifest sometimes as an improvement in latency rather than as an improvement in amplitude alone. So a better response at 1 kilohertz. So if you see a better response at 1 kilohertz than at 500 Hertz, beyond a specific upper and lower limit of normal, then your patient very likely has a hydropic condition. Now, as I said to you earlier, this is not 100% in the normal population. And for example, in our normal population, where we had 25 healthy young volunteers, 3 of those had a better response at 1 kilohertz, and they were asymptomatic. So we set our upper limit and lower limit of normal based on this possibility of finding this. And based on that, our normal values, and this may be different, and it isn't indeed different from what you may find in literature, to see and to determine based on amplitude that there is frequency tuning, we want to see an increase in amplitude from 500 Hertz to 1 kilohertz of at least 2.5 times. This is our normal value in our laboratory. Like I said, you need to obtain your own normal value because you will have your own experience of your own normal population as to what an increase in amplitude at 1 kilohertz can be allowed and should be allowed, and when that can be said to be a manifestation of a hydropic condition. So I'm showing you an example here of a patient who actually has both Meniere's disease and vestibular migraine. This is a 47-year-old patient that was presented to us, who from 23 years old had episodic dizziness, rotatory vertigo, 1 to 2 times per year, which increased to once per month until 2015. The patient was given topiramate oxcarbazepine with significant improvement. The migraines were rare, but there was sensitivity to sound and light during the episodes. So based on the clinical picture, the patient very likely at that point had vestibular migraine. But in the previous year, prior to seeing me, the patient then developed new onset tinnitus that wasn't present before. Unsure which ear, according to the patient, and both ears felt blocked. And again, this was something new that wasn't present before. The pure tone audiogram on the left did indeed show low frequency hearing loss with regards to left ear stimulation. And I'll show you here the cervical vestibular evoked myogenic potential. This is 500 hertz stimulation, and this is 1 kilohertz stimulation. Left ear, right ear, left ear, right ear. And what I see often, in my cases, and this is an example of frequency tuning for me, is that at 500 hertz, with regards to the ear, the same ear that showed low frequency hearing loss on the pure tone audiogram, there was an unobtainable response at 500 hertz and an obtainable response at 1 kilohertz. So here we have an example of frequency tuning, not with regards to increase in amplitude, not even with regards to normalization of absolute latency of P13, but an absent response to a present response as a manifestation of improvement in response. And why am I showing you this? Because if you are in a laboratory that does only 500 hertz, this would be difficult to interpret on its own. An unattainable response at 500 hertz, which could be anything. Of course, you do have the pure tone audiogram that showed the low frequency hearing loss. And together with that, then yes, you could conclude that this is due to a hydropic condition involving the saccule. But for argument's sake, if the audiogram had remained normal, and it can remain normal in a hydropic condition sometimes, especially when the hydrops does not involve the cochlea, this would have been difficult to interpret on its own. So if you do have the ability to stimulate at specific frequencies, and you are presented with a case with a differential diagnosis of whether your patient has Meniere's disease or vestibular migraine, especially when the pure tone audiogram is normal, it is recommended on all these occasions to do stimulation, not only at 500 hertz, but at 1 kilohertz as well. And like I said, you will not only see something like this, an unattainable response to a present response, and not only will you see an increase in amplitude sometimes when going from 500 hertz to 1 kilohertz, but you can also see a normalization in latency. And I show you here such an example here. This is similar to what we saw in the previous case with regards to the left ear, unobtainable to present when going from 500 hertz to 1 kilohertz, but focus on the right ear here, where I do get a response with regards to right ear stimulation, but the latency is prolonged here. I have a latency here of 20 and 20.7 with regards to the CVEMP. The upper limit of normal in our laboratory is 20.1 milliseconds. So if it is not prolonged, it is at least at the upper limit of normal. But when going to 1 kilohertz, the latency normalizes and is reduced to 13 and 14 milliseconds. So an improvement in latency rather than an increase in amplitude, but a better response nonetheless with regards to latency. So you can have a better response at 1 kilohertz, but using with regards to the parameter latency rather than the presence or absence of a response or amplitude. Now, sometimes you may get an example of frequency tuning that may not involve the CVEMP, but the OVEMP. Does that indicate utricular predominance with regards to the hydropic condition? Probably not, maybe not, and I'll explain that now. So I have a case here of a patient complaining of headaches, probably not migraine, mostly frontal with regards to the distribution of the headaches. Spontaneous rotational vertigo episodes, 4 per month. Tinnitus in the right ear, but fullness in both ears. The MRI, pure tone audiogram, and the calorics were all normal. So an example of a case where the pure tone audiogram remained within normal limits. The CVEMP remained within normal limits. Yes, I will point you to here that what you may be seeing here is that for the left ear, with regards to the CVEMP, the amplitude ratio, because I take muscle contraction into account, very important, I cannot emphasize this enough, the ratio does increase from 2.7 to 5.3. There is an almost doubling, but like I said, we need to see more than a doubling to consider it significant. But yes, indeed, there is a doubling of amplitude for the left, especially when you compare it to the right side. But let's say, for strictly speaking, that this is still within normal limits to avoid subjectivity. But when I did the OVEMP in this case, the OVEMPs were unobtainable bilaterally at 500 Hertz and present at 1 kilohertz. An example of frequency tuning, this time with regards to both ears, and this time with regards to absent to present, and this time with regards to OVEMP. So in such a case where you see frequency tuning in OVEMP rather than CVEMP, does it mean that the hydropic condition is predominant in the utricle rather than the sachial? Very likely not, because we have the phenomenon of saturation with regards to the CVEMP. So in this case, there may have been the possibility of the CVEMP increasing to more than 5.3, but it couldn't because of saturation. And this is the disadvantage a little bit with regards to CVEMP, that you can only inhibit muscle contraction so much. And the reason that it couldn't increase to more than 5.3 is that the CVEMP reached the maximum inhibition that it could reach based on the patient's muscle contraction. So because this is an inhibitory response, you can only inhibit muscle contraction so much, and it may have reached the limit of how much you could contract. But the OVEMP does not have this disadvantage. This is an excitatory response. So there is no limit to how much you can excite the utricle or the amplitude that you can reach. And here I show you an example of a case reported frequently in the literature with regards to superior semicircular canal dehiscence syndrome. And the results can be remarkable on many occasions where here or with left ear stimulation, I get a huge response on the side of the dehiscence. The upper limit of normal in our laboratory is 7.9 microvolts. This is what we normally get in our laboratory, around 3.3 to 6 microvolts. But with regards to the side of the dehiscence, we get a huge response of 12 to 15 microvolts. And this is the CT scan where, in fact, yes, even though it appears to be bilateral, that you can see here a continuation with the posterior brain cavity with regards to the left side, the left ear, whereas the right ear, there is indeed a thin sliver of bone. And indeed, this is not a dehiscence, but the dehiscence is on the left-hand side. And I show you an example here of inferior vestibular neuritis. And this emphasizes also the fact that brainstem auditory evoked potentials cannot be used, in fact, in almost all cases, I believe, of vestibular dysfunction. And this is a case of proven inferior vestibular neuritis, where the brain is completely within normal limits. The ocular is also within the normal limits bilaterally. The CVEMP is normal with left ear stimulation and absent with right ear stimulation, suggestive of a right inferior vestibular neuritis. So you can use vestibular evoked myogenic potentials to rule out, especially inferior vestibular neuritis, where the nystagmus can be difficult to define, especially if you are not very experienced in characterizing the nystagmus findings in your patients, to avoid sending the patient to do a brain MRI. Vestibular paroxysmia, or if you believe that this condition exists, because there are those that believe that perhaps, or feel that perhaps this condition may not actually exist. A case of a patient here with a vascular loop in the internal auditory canal on the right. The patient did describe tinnitus and vertigo, but not so as frequently as one might expect, as what is described in the literature with regards to vestibular paroxysmia, or in other words, neurovascular compression of the vestibular nerve. There does appear to be a vascular loop in the internal auditory canal. Those who are suspicious of this condition are aware of the fact that there is again no one-to-one association, and there are those who have MRI findings of vestibular or vascular loop that do not have symptoms, and vice versa. And maybe one can say that one may be unsure of whether the vascular loop here is causing the patient's symptoms. Well, what I can show you here is that it appears to be at least doing something, because on the side of the vascular loop, if this response is not unobtainable, it is at least disorganized. So on the side of the vascular loop, the CVEMP appears to be at least unobtainable, where on the other side, it is a normal response. And I've actually seen a similar case like this recently, where again, the CVEMP is unobtainable on the MRI of the vascular loop. But then you may argue, yes, it affects the CVEMP or the VEMP in general, but can this describe what the patient is experiencing? A good question, but as with all things, all paramedical examinations, not only VEMPs, but in all specialities, require clinical correlation. So that's the last case I wanted to present. These are the colleagues that I would like to thank as well here, that entrust me with the cases. But two of my referrals are from ENT colleagues, which I'm very happy with. But I also have a very interesting. So you will see these cases in neurology field, and neurology of vestibular dysfunction as well. And as promised, I show you here my email. So my presentation, send me a message on my email as shown here. And I'll with the parameters that you can use to change your biop system if you have a biop system in your laboratory. Also, if you want me to help you on how to use your system to do VEMPs and your specific system, and how to change your specific system, I can help you there as well. You can send me your waveforms. Are these waveforms good? Are they not good? Do they need improvement? I can help you there as well. And also, if you have specific patients, specific cases, and you want to ask me, in this specific case, will VEMPs help me? Again, I can help you there as well.